such a pleasure to be here today, to have an opportunity to speak with you all. And it is especially meaningful to me to be invited to give a lecture named for one of my personal heroes, Karen Watson. I have been aware of her for my entire career, and I met her when I was an assistant professor at UT Austin. She really is one of my personal heroes, and so it's such an honor to be here today and to have the opportunity to give this talk. What I want to share with you today is a vision for how bioengineering and biophotonics can be used to address disparities in global health. And so what I thought I would do is share with you two examples from our work where we're trying to think about how, as engineers, we can bring technology to address health disparities that exist in some of the poorest places in the world. And I want to talk today about two examples. The first one that I'll talk about is how do we try and prevent cervical cancer globally? And the second example that I want to talk about is how do we end preventable newborn death around the world? So I'm going to start with cervical cancer. And when you think about preventing cervical cancer and global ambitions to do that, we really actually have a lot of tools at our disposal to prevent cervical cancer. We have a vaccine to prevent infection with human papillomavirus, the cause of cervical cancer. We are able to screen women, asymptomatic women, using either the pap smear or an HPV DNA test. We can diagnose pre-cancerous lesions on the cervix using colposcopy and biopsy, and we can actually treat those precancerous lesions using an outpatient therapy called LEAP. And so in some ways, if you think of the cancers that are preventable, cervical cancer is the most preventable cancer. And if we cannot do this for cervical cancer, we don't have a lot of hope of preventing other cancers. So why is this still such a challenge? And I think this map illustrates part of the reason. This map shows the incidence rates of cervical cancer worldwide, and red and yellow represent high rates of incidence. And you can see that in poor countries in sub-Saharan Africa and in Southeast Asia in particular, the rates of incidence of cervical cancer are orders of magnitude higher than they are in high resource settings. And in fact, 85% of cancers of the cervix occur in women who live in low and middle income countries. All of these are theoretically preventable, either primary prevention with HPV vaccination or secondary prevention with screening. Yet they still occur, and women die at a young age. The peak incidence for cervical cancer is in the late 40s, early 50s. They die a painful death at a young age needlessly. And this is not only a challenge outside the United States, it is also a big challenge right here in the state of Texas. If you look at the Rio Grande Valley, the 4 counties at the southern tip of the state, it's a population of about 1.3 million people, 90% Hispanic, 40% who are living in poverty. And in that population, actually fewer than 10% of women who should be getting screened for cervical cancer are actually getting screened for cervical cancer. And as a result, in the valley, we have 31% higher rates of cervical cancer than we do in the rest of the state. So this is a challenge in low resource settings, truly in a global context. So I want to come back to each of these and think about where are there opportunities for technologies to play a role. So let's take a look at prevention with the HPV vaccine. So cost right now is a major barrier for the HPV vaccine. The cost of a dose of the vaccine is about $100 here in the United States. If you're in a Gavi eligible country, you can buy a dose of vaccine for about $4.50, but that is about 10 to 100 times higher than the cost of other childhood immunizations that are commonly recommended. So cost is still a barrier. It's a 3-dose series of the vaccine right now, although recent data indicates that women, both girls and boys, who get 2 doses of the vaccine have lifelong immunity. Even in the United States, the rates of immunization are still woefully low. We have fewer than 60% of girls have received 3 doses of the vaccine in the United States, and fewer than 60% of boys have received 3 doses of the vaccine in the United States. So even in high resource settings, we are not reaching the people that need to be vaccinated to prevent cervical cancer. So I mentioned that knowing whether or not you've had the proper number of doses to provide protective immunity is important because each dose of the vaccine is expensive. And so one of the things that we began to develop in our lab is we began to develop a tool to determine whether or not a patient has had an adequate response to vaccination against HPV. And so normally what you would do is you would take a sample of blood and you would look to see, are there antibodies against the human papilloma virus? The problem is if you're doing this in a low resource setting, you take the blood, you take it back to the lab, you get the result, now you go to find the patient. Connecting the results back with the patient is difficult in a low resource setting, and ideally what you'd like to do is capture them right there at the clinic and give them a shot if they don't have adequate immune response. And so what we've developed is a paper-based diagnostic where you can apply just a single drop of blood and you can determine whether or not that patient has received sufficient doses of the vaccine to have adequate immune response. And so this is everything that you need to do the test is shown in this picture. So you've basically got an alcohol wipe, you've got a lancet so you can get a drop of blood, and you've got a Band-Aid so you can put it on over the spot where you've got the drop of blood. You've got a little vial of buffer, we use PBST. You've got a transfer tube to measure out an amount of blood that you apply to this pad, and then these tubes that you use to hydrate these reagent-containing pads in our paper and plastic device. What you do then is you peel off this piece of paper, and that will expose a sticky surface. You fold this device together, and then what happens is blood will allow the red blood cells to get trapped in this plasma separation membrane. The plasma will flow down the strip. There is a test zone, 3 test zones, all of which contain the same virus-like particles that are used to elicit that immune response in patients. And so if antibodies to those virus-like particles are present, they will adhere to the test zone. Then what you do is you flow wash buffer past that. Now we have gold nanoparticles that are conjugated again to another antibody, a recognition antibody that will bind to the patient's antibodies if they're present, a second wash step, and then you look at these 3 test zones to see if the lines have turned purple because you have the sandwich assay formed. And so for patients who've received 3 doses of the vaccine, here you see the control spot lighting up. They've got enough antibody to fill up all the spots on what's called a ladder assay. Here's a patient who received 2 doses of vaccine, still enough antibody to fill up all 3 spots there. But if you've only gotten 1 dose of the vaccine or no doses of the vaccine, you just see the control zone lighting up. And so we've tested this in Houston. In the medical center, we recruited 28 college students, and we took a drop of blood, we ran the test, and we had access to their medical records to know how many doses of the vaccine they had received. And what we'd like to do is to separate out those people who've had 2 or 3 doses of the vaccine from those people who've had 0 or 1 dose of the vaccine, and in particular be able to separate out those who are naturally infected with HPV as well. And so we've run controls looking at individuals who are naturally infected. We're now just getting ready to test this in the field, and so we're working in Costa Rica to do the first field evaluation of this tool. We can put together one test for about a quarter at low volume, and so it's much cheaper than just giving another dose of the vaccine. So when we think about screening, and because the vaccines right now don't cover for all strains of HPV, it's still necessary for the foreseeable future, even for women who've been vaccinated, to have screening tests, either with the pap smear or with an HPV DNA test. I work in Brazil with a wonderful hospital called the Barretos Cancer Hospital. And this is a hospital that's located in São Paulo state, but it's located about a 6-hour drive outside of São Paulo in a very rural part of Brazil. And this is a hospital that is dedicated to providing cancer care for the rural poor in Brazil. And it's funded largely with donations from Brazilian celebrities and from Brazilian ranchers. And one of the things that they've done at this hospital is they've developed mobile screening units. They're essentially semi-trucks. And inside there is a healthcare facility that can do things like pap smears or can do HPV DNA tests. So they take the pap smear sample in this mobile truck that travels all over up into the Amazonian region of the country, all over the country. They take the pap smear, but they have to drive it back to the hospital, and then they run the test at the hospital. And if a woman screens positively, she's invited to come back to Barretos for her follow-up care to diagnose whether or not she has precancerous lesions and actually treat them. And that care is free, as is the cost of transportation is covered for patients, and they can bring their families and there's free housing. So this hospital has tried to do absolutely everything they can to ensure that women who screen positive actually follow up and get the care that they need. But despite that, what they found is that only about half of women who have an abnormal pap test come back to the hospital for the follow-up care that they need. And so all of the half of the resources that get invested into the screening program essentially are wasted because the women who are identified are not able to come back for care. And so we've been working to address this in two different ways. One is to develop a test to identify whether or not a woman is infected with HPV right there at the point of care so that you could treat her if her test was positive. The way that we detect HPV DNA right now is basically a cervical swab is collected, and then that cervical swab is placed into a lysis buffer to open up the cells. It's heated up to denature any DNA that might be present, and then we take strands of RNA that are complementary to the HPV DNA. If HPV DNA is present, you get an RNA-DNA hybrid. Then what you do is you carry out an ELISA assay to detect those RNA-DNA hybrids. We can't do it on a simple lateral flow because there's not enough DNA present for it to be detectable on a simple lateral flow assay. And so the way that's done today is you do this hybridization, then again you make a sandwich between your capture antibody and your detection antibody, but now we're going to put an enzyme here, and that enzyme is going to catalyze a color change in a colorimetric substrate. And we can amplify the response so that we are able to detect down to levels of 1 picogram per ml of HPV DNA. And so the standard of care right now for doing that in the field is a test that's made by QIAGEN. It's called CARE HPV, and it was developed with funding from the Gates Foundation to provide an affordable test for low resource settings. And this is really the standard of care in poor places right now for HPV DNA testing. And you can see you've got a 96-well plate. What that means is that you have to collect specimens from 96 patients in order for this to be cost effective, because the plate costs 96 times $5. Each assay is only $5, but you've got to run 96 in parallel. And so you've got a plate shaker here that's necessary to heat and shake the plate. You've got a plate reader here, and this walks you through all the steps to do the assay. Everything is written by hand on these little 96-well plates, and all the results are transcribed by hand. And so you can imagine the potential for getting results confused. So typically what happens is a clinic will collect up samples until they have 96, then they'll run a plate. You can't really do this in real time. So we've been working to use that same paper and plastic approach to come up with an HPV DNA test that is affordable to run at the point of care. And so in an ELISA assay, you have to build in this ability to do amplification and to deliver the reagents sequentially to do that amplification. And so in the current version of our test, again, it's a paper and plastic device about the size of a credit card. It has a little nitrocellulose strip We're going to place our capture antibody to capture our RNA-DNA hybrids right here. We will add our sample, and right now we're doing our sample processing off the device. Essentially, you collect your smear, you put it in a tube of lysis buffer, and then you immerse it in boiling water for 5 minutes. And then you place a drop of it right here on your sample pad. And then you rehydrate with buffer all of these pads that contain the various reagents. Here's your second antibody. Here's a horseradish peroxidase that's conjugated to streptavidin, and then our reagent so that we'll get the colorimetric result that we want and a couple of other wash steps. We're working in El Salvador to test this with an NGO that is scaling up HPV DNA testing all across the country of El Salvador. And this is one of our graduate students, Chelsea Smith, in El Salvador with the first 4 tests that were run in the field. So these 2 tests were run from samples that tested negative according to the QIAGEN test. And you can see there's no dot that's present. These are 2 that were run from women who tested positive according to the CARE-HPV test. And you can see you're able to read it visually. And so we're really now just underway in the field evaluation in the first pilot setting. But we can run this test in 30 minutes, and it costs us about $1 to make one of these HPV diagnostics at low volume. So once you have a positive screening test, typically what happens is women undergo a confirmatory diagnostic test to be sure that they have precancerous lesions, in which case they'll be treated using an excisional procedure. And right now that involves doing an exam that's called colposcopy, where you use a low power optical microscope to view the cervix. You apply a little bit of acetic acid or vinegar to the cervix, and areas that are abnormal turn white. It's not very specific, and so they biopsy those abnormal areas, and then you have to send them down to the pathology lab. And again, it's a couple of weeks before you get those results. So if you're trying to do this in a rural area of whatever country you live in, it's a barrier for women that have had to travel a long way to come to the clinic. And so what we've been doing with our colleagues in Brazil is to think about, can we bring the diagnostics to patients in the same way that they're bringing the screening to patients? And so we built a mobile diagnostic and treatment unit. And you can see here, it's essentially just a van. And inside, I don't have a picture of the inside of the van. Inside of the van, there's an examination table. And there's a colposcope. There is cryotherapy to immediately treat if patients need treatment with cryotherapy. And then we're evaluating a fiber optic microscope that allows you to visualize the same cellular changes that pathologists would look at in the biopsy to determine if precancerous lesions are present. So we've carried out in Barretos a clinical trial of 200 women where we compared, did they actually come back and complete the diagnosis and treatment if they were either recalled to the central hospital or if they were seen with this mobile diagnostic unit. They were randomized geographically based on where they lived, and then in the standard of care arm, they just got recalled back to the hospital for standard follow-up, but we also imaged them using our microscope. If they were seen in the mobile diagnostic and treatment unit, they got colposcopy, they got imaged with our microscope, they got biopsied, and then they got treated if they needed it. And we compared the rates of completion of diagnosis and treatment follow-up, and we looked at the accuracy of our imaging method. And so what we're doing in our imaging method is we're trying to visualize the nuclei within the epithelium of the cervix. In precancerous lesions, what you find is that those nuclei become enlarged, they become pleomorphic, the shapes are more random, and they are more crowded. That's easy to look at in a biopsy. What we have done to try and look at that right at the point of care when the tissue is still in the cervix is we've developed a fiber optic fluorescence microscope. And you can see the device right here. It's run with a tablet computer. And inside here, essentially, you've got a blue LED that excites the fluorescence. You've got a filter cube to direct your excitation light to your fiber optic probe, and then to direct the emitted fluorescence onto a very inexpensive CCD camera. And we can capture images with 4-micron spatial resolution at video rate. And we can build one of these systems for a total cost of about $1,500. We apply a fluorescent dye to the cervix. It's called proflavin. It's a topical antiseptic that happens to be fluorescent and that stains nuclei so that they are brightly fluorescent. And so here's what you see inside the van. Here's the exam table, here's the colposcope, and here's our fiber optic fluorescence microscope. The provider can either look at the image on the tablet or there's a screen that's mounted above the exam table. And so when you place the fiber optic probe on the tissue, essentially at video rate, you can see the nuclei that are in contact with the distal tip of the fiber probe. The field of view is about 720 microns, and each of these little white dots represents a nucleus. When the physician is satisfied with the image, they press a foot pedal, and then the image is processed in a procedure that takes about a second. The nuclei are segmented, and we identify any that are abnormal based on their size and shape. The abnormal ones are outlined in red, and then we calculate the fraction of nuclei that are abnormal. If it's below a threshold, this bar is green. If there's a precancerous lesion present, as there is in this case, where you see that the nuclei are much larger, the shapes are much more random, they're more crowded, you can see we identify many more abnormal nuclei. We've crossed our threshold, the bar turns red, and that's the cue for the provider to say, indeed, this is a precancerous lesion. I should either biopsy it or go ahead and treat the patient. And so our colleagues in Brazil took the van out into the field, and you can see here some of the conditions that they have to traverse to get to their patients. In some cases, they're going on barges across rivers. And what we found in the study was that if we looked at the rates of follow-up in the standard care arm, where patients were invited to come back to the hospital, only 64% of patients actually completed the follow-up that they needed. And this was despite a research team that was reaching out 20 times to try and contact patients to get them to come back. They didn't stop until they had made 20 attempts. In the case of the mobile diagnostic and treatment unit, we had 87% of patients who actually completed the follow-up that was needed. And then we compared the accuracy with our diagnostic system to the accuracy of the traditional technology, colposcopy. And the gold standard in this case was biopsy. And what we found was that we slightly improved in both cases the sensitivity and the specificity using our high-resolution microendoscope compared to that of colposcopy. And so we're just now getting underway with a much larger study, a study of 12,000 women, where we'll be looking to evaluate whether or not the sensitivity and the specificity are statistically equivalent to that of colposcopy. And finally, in our group, we're not doing work to look at can you bring treatment closer to patients, but our colleagues in El Salvador are very interested in this. And so right now, cryotherapy is the standard of care using these big, heavy tanks of CO2 gas. They are expensive. The cryo guns that you use to provide the treatment tend to jam in the field. It's really hard to do this in rural areas. And so they're working with a new kind of cryotherapy device that is electrically powered and much less expensive. So they're trialing the cryo pen. And our hope is that by bringing all of these technologies together, what we'll be able to offer to women is the opportunity in one visit to do what now requires 4 to 5 visits, and that is to collect a cervical swab and test to see whether or not a woman is infected with HPV. If she is, then immediately move on to high-resolution imaging to determine whether or not there are precancerous lesions present. Because most women who are HPV positive don't have precancers. Only about 10% of women will actually go on to develop precancerous lesions. And then provide immediate treatment with cryotherapy, so you can do this all in a single visit in a cost-effective way. And what I'm really most excited about is the opportunity that we found to take what we've learned from our efforts in Brazil and bring that back to the Rio Grande Valley. And so this is a mobile van that's parked outside a school in Brownsville. This is a mobile health clinic that's run by the UT Medical School in Houston. This is staffed by a nurse practitioner. And right now, the only diagnostics that they're able to offer are rapid strep tests, and they can measure your hemoglobin. What we would like to do is provide the ability to do cervical cancer screening as well as cervical pre-cancer treatment if it's needed. And I think there's opportunities to think beyond middle-income countries like Brazil and high-income countries like the United States. When we think back to that map that I first showed you of where the vast majority of cervical cancers occur, they occur in low-income countries. Our group does a lot of work in Malawi. And I was in Malawi a few years ago, and I was talking to this guy, Alex Nglande, who is a community health worker. And he runs what I think is one of the best community health outreach programs in Malawi. And so I asked him, I said, Alex, I am interested in cervical cancer prevention. I'd love to know some of the challenges that you and your team encounter when you're thinking about cervical cancer prevention. And I was really humbled by Alex's answer. So Alex reached inside his desk, and he got out this bottle and these little cups, and he said, we have so many problems with cervical cancer. He said, my team is taking care of a lot of women who are at home dying from cervical cancer. And we provide them with liquid morphine to manage their pain. And so we leave these bottles of liquid morphine for their family members and these little cups so that they can dose the liquid morphine. And it's really hard at night in the dark for them to be sure that they're providing the proper dose of morphine. And so if you and your team of engineers can help us figure out how to better dose liquid morphine, that would be a big help. And I think that really encapsulates the challenge of cervical cancer and other cancers in low-income countries, is that the focus right now is on how do we palliate pain at the end of life, not on how do we prevent cancer in the first place. And so I think we have a lot of work to do to get to that point, but I'm really excited about the opportunity to think about the role that affordable technologies can play in helping that come to be. And I think education of providers at the same time that we're educating students is a really interesting way to think about that. And so I told you when providers do colposcopy, they put acetic acid on the cervix and they wait for those spots to turn white. And right now the way that you train someone to do that is you show them some pictures. You say, here's a picture of the normal cervix, here's a picture of an abnormal cervix, this is what it looks like before and after acetic acid. And we have undergraduate students from Rice and Malawi working together to think about how can you come up with educational tools to better train providers. And so this last summer at Rice, we had this group of 3 students working on models of the cervix that actually will turn white when you put acetic acid on them. And so they figured out how you can paint them with paint that will turn white when you apply, in this case, warm fluid to it, and will turn the right shade of white and will fade in the same way that the actual cervix does. And so these 2 students, Wahid and Mary, that you see here, they went back to Malawi to continue their education at Malawi Polytechnic, but they got invited to go to Mozambique when Mozambique was working with our colleagues from Brazil to try and train more providers to learn how to do colposcopy. They got invited to come and bring their models, and it was really a wonderful opportunity for them to come in and be the local technology experts who can demonstrate what it's possible to do with bioengineering to try and improve health. So in the second part of my talk, I want to concentrate on a second example, which is ending preventable newborn death. And this is a project that we first started working on really in 2009. And it was motivated in part by lack of progress toward the Millennium Development Goals. So the Millennium Development Goals is a set of goals that was adopted by the world, and these were a set of goals that the world was to achieve by 2015. You can see there were 8 Millennium Development Goals that ranged from goals around eliminating poverty, improving education, reducing maternal mortality, and reducing neonatal mortality. And we're just now looking at whether or not we achieved these goals. And I want to show you some data on where we did well and where we did not do so well. And so what I'm going to show you is by MDG, the number of countries that either met the goal or that are seriously off target. And seriously off target means they are 15 years or more behind schedule to meet the goal. So if we look at the goal to reduce the number of people living below $1.25 a day, we can see that 74 countries in the world met that goal and only 22 are seriously off target. Similarly, if we look at the goal to have equal numbers of girls as we have boys in school, 65 countries met that goal, only 28 are seriously off target. But if we look at the world's goal to reduce infant mortality, we only had 6 countries that met that goal, and we have 77 countries that are 15 years or more behind schedule to reach that goal. And it's even worse for maternal mortality. We have 88 countries that are more than 15 years behind schedule to achieve that goal. And really, the challenge for newborns in some ways is very different than the challenge for children. If we look at how the world did to try and reduce child mortality, we actually did pretty well. This shows the number of children under the age of 5 that died over time in the world. And we did a good job of bringing child mortality under control, mostly by strengthening primary care and childhood vaccination. But if we look at newborn death, that's death in the first month of life, we've made far less progress. And in part, that's because technology plays a bigger role in keeping small and sick newborns alive. And this is a graph that it really troubles me so much. I lose a lot of sleep over this graph. It's a graph that came from a paper that was published in 2008 by a group that was looking at how long will it be before different regions of the world are able to reduce the death rate for newborns down to that of high-income countries. And so this is the neonatal mortality rate. This is time right here. And this is Africa in red. And if we look at current rates of progress at how long it will be before a baby born in Africa has the same chance of surviving as a baby born in North America, it is 150 years. So if we just keep doing what we're doing, in 150 years, we will have closed the gap. And I think that's just too long. We do, as I said, a lot of work in Malawi. And Malawi has one of the highest rates of preterm birth. It has actually the highest rate of preterm birth in the world. 18% of babies who are born in Malawi are born prematurely. It's 6% for reference in the United States. And if you look at the leading cause of child death globally right now, it's complications of preterm birth. That's where we are with the state of newborn health in the world. And so I visited Malawi for the first time in 2006. And this was a picture that I took on that first trip. This is the nursing station in the neonatal intensive care unit at the largest teaching hospital in the country. And I think what you see in this picture sort of tells you everything you need to know about why Malawi has so many challenges with poor outcomes for preterm babies. There were 60 babies who were in the NICU, and there were 2 nurses who were on staff, and they had virtually no form of technology to provide care for those babies. And if you think about going to a NICU in the United States, you've got every imaginable form of technology that is available. Lack of technology is not the barrier in the United States. But the really tragic thing in Malawi, the even more tragic thing, is that when you think about the technologies that are needed, people have tried to donate them, but they just don't work when the donations get there. So let's take a look at the leading cause of death for preterm babies. That's respiratory distress. So here you see his head is cut off, but this is my good friend Kandwani Kawaza, who is the only neonatologist in the entire country. It's a country of 16 million people. And this is a very typical day at work for Kandwani. He's got 4 premature babies in this bed. And babies who are born prematurely suffer from something called respiratory distress. And in respiratory distress syndrome, what happens is because these babies are born early, Their lungs lack surfactant. And so the surface tension is very high in their alveoli. And so when they exhale, what happens is you get alveolar collapse. And when they try and inhale, it takes a lot of energy to reinflate their alveoli. For babies that have enough surfactant, when they exhale, the alveolar volume decreases, but you don't get alveolar collapse. And this is what that looks like. So this is a baby that suffers from respiratory distress syndrome, and you can see he's breathing really, really rapidly, and all his energy is going into breathing. This baby needs support with oxygen and possibly with a technology called CPAP, continuous positive airway pressure. On that first trip that I made to Malawi, just down the hall from the NICU was this room. And this is the equipment graveyard. Every single hospital that I have visited in Africa has a room that looks like this. And it is full of equipment that has been donated by people who really wanted to help improve the situation there. And then that equipment gets plugged into an electrical system where you've got large line voltage spikes. It's operated in an environment that's not air conditioned, where the windows are open, it's very humid, it's very dusty, there might be insects, there might be rats, and they quickly fail. And so in this room were 83 broken oxygen concentrators. And if any one of those oxygen concentrators worked, it would have been being used in the NICU. And so really what is needed in this environment is a different kind of technology that is explicitly designed to work in a place where it is affordable, where it is robust and rugged, where it is very simple to maintain, and where you don't need consumables that are just thrown away, because the supply chain is so fragile and there's no money to purchase those consumables, or very little money to purchase those consumables. Also on that trip, that first trip I met this woman, Elizabeth Molyneux, who's another one of my heroes. She is a pediatrician who moved to Malawi in the early 1970s and lived there ever since, built the pediatrics department at the medical school, but I think is really an engineer at heart. And she spent a lot of time working with us and our team to help us understand where were the needs for technologies in this environment. One of her challenges was keeping babies warm, and so she worked with local craftsmen to build what's known as the Malawi hot cot. It's a simple little crib that uses light bulbs to warm the air and to keep the babies warm. And she explained to us some of the needs that she had, such as providing phototherapy to treat neonatal jaundice. But she said one of her biggest needs was to have CPAP, a technology to help provide breathing support to premature babies. You saw that little baby could breathe on his own. The challenge isn't breathing on his own. The challenge is the work of breathing until his body can make enough surfactant, which takes 1 to 2 weeks. And in CPAP, what you do is you put a set of soft rubber prongs in a baby's nose, and you blow in a mix of air and oxygen at constant pressure. And what that does is that pressure just prevents that alveolar collapse upon exhalation. And so it reduces the work of breathing. And so babies are typically on CPAP for about a week, and then they graduate and they do just fine. And so what Liz said to us is, I need a bubble CPAP device that doesn't cost $6,000 and that doesn't require room air and room oxygen. We came back to Rice and we tasked a team of senior undergraduate students who are doing their capstone design with building a low-cost bubble CPAP device. And you can see this is their prototype. It looks very much like a student prototype. It's in a little plastic shoebox that they bought at Target. And what they put inside here was 2 aquarium pumps. They wanted a flow driver that was very inexpensive and that was designed to run forever. And they took their system over to Texas Children's Hospital, and they demonstrated that it provided the same flow and pressure as the systems that were used to treat babies at Texas Children's Hospital. But unlike the $6,000 price tag, they were able to build their device for $150. And so the woman that you see here, Jocelyn Brown, traveled on an international internship the summer after she graduated to Malawi. And she demonstrated that system for the nurses who work in the NICU. And they told her everything that was wrong with the device. They said, this plastic box, it is going to break. They said, your device is designed for 110-volt system. we have 220 here, your step-down transformer is going to disappear. It's too complicated to plug some of the tubes in the front and some of the tubes in the back. The icons all need to be pictorial. But can we keep it and use it because we really need it? And so Jocelyn came back to Rice, and she made all of the improvements that they told her were needed. And we wrote a grant to USAID, and we got $200,000 to carry out a clinical trial of CPAP in Malawi. And I think this is maybe one of my favorite pictures ever. These are the wonderful CPAP nurses that were hired to carry out the first clinical evaluation of CPAP in Malawi. And Jocelyn actually moved to Malawi, and she lived there for 2 years, where she helped carry out this clinical study under the supervision of Dr. Molyneux. This is one of the very first babies that was treated with CPAP in the trial. And what we did was we compared survival to discharge for babies that were treated with nasal oxygen, at the time the local standard of care, to those who were treated with CPAP. When CPAP was introduced in the United States in the early 1970s, what we saw was rates of survival for this population went from 25 to 70%. And what we found in Malawi was that, again, for this population of babies, the survival in the group treated with oxygen was 23.5%. The survival for the group treated with CPAP was 64.6%, really coming very close to the improvement that was seen when CPAP was introduced in the United States. And so we went back to USAID, and we went to the Ministry of Health in Malawi, and we said we want to scale this up across the country of Malawi. Malawi has about 30 hospitals that are run by the Ministry of Health. And we were fortunate to get support from USAID and to get buy-in from the ministry. And so this is our wonderful team of CPAP associates, some who came from Rice, some who came from the Ministry of Health, but all who worked together to roll CPAP out across the entire country of Malawi. And what they did is they went into every hospital and they provided this cart and they provided a CPAP machine. You can see here it looks a little bit different because now it's being produced by a commercial manufacturer, Third Stone Design, a company located in San Francisco that licensed the technology. They provided an oxygen concentrator, a suction machine, all of the supplies that you need to do CPAP. They collected baseline data before CPAP rollout, and then they collected survival information after CPAP was rolled out. And absolutely essential to this rollout was to engage nurses all across the country and train them to use CPAP. And this is Florence, one of those original nurses that was hired to do our CPAP study. And Florence is the one who actually came up with the name of the device. So the local language in Malawi is Chichewa, and Pumani is a Chichewa word that means breathe restfully. And now when I go to Malawi and I go to a district hospital, if I say, hey, I'm here from Rice University, nobody has ever heard of Rice University in Malawi. But if I say, hey, I'm here with Pumani, they all know exactly where the Pumani device is. And it was very important that the technology have a name that reflected the local involvement in its development and its dissemination. And so Pumani was licensed by Third Stone Design. They've taken it through the international regulatory approval process. And Jocelyn actually now lives in San Francisco, and she's the product manager for the Pumani line from Third Stone Design. And Pumani has been able now to place this device in 23 countries. And so we needed grant support to get it rolled out in Malawi in one country, but because we partnered with the private sector, we were able to do the next 22 countries essentially for free through our collaboration with Third Stone Design. But it's not enough to just have CPAP. And you know, when we first started our rollout of CPAP, I really naively thought that this is going to be all it took. You know, that we were addressing this very big cause of death for premature babies, and we were going to be done after we got Pumani rolled out. And you know, what I came to learn and what our team came to learn is that if you don't take a holistic approach, you're not going to be successful. And what we found when we went to these community hospitals in the rural part of the country is that the NICUs there didn't have room heaters. And so they literally had no way to keep babies warm. And we went back and we looked at our data in the pilot study. So this is our data at the teaching hospital. And what I plotted here is this is the mean temperature of the baby versus the subject number in our study. And the symbols that are filled in are babies that survived, and the symbols that are not filled in are babies that died. I've never, in all my career, I've never seen a chart where the subjects were stratified in such a distinctive way. Normal temperature for a premature baby is 36.5 to 37.5 degrees. And in any NICU here, they work really hard to keep those babies at the right temperature using incubators. And you can see in this teaching hospital how many babies were below that temperature, and they just did very poorly. And so as we began to roll out CPAP, what we found is that the places that we were taking CPAP to, they didn't have ways to keep the babies warm. And so if you look at the first 1,700 subjects that were treated with CPAP in this rollout, only 1,100 of those actually had their temperature taken on admission. And only 500 of those immediately got put on CPAP, and only 470 of those were admitted on the day of birth. And so if we look at those babies that had an actual admission temperature, so now we're going to look at the blue, the red, and the green. We can't look at the gray, all of the gray, because these babies didn't even get their temperature taken. But if we look at, first of all, look how low these temperatures are. These babies are coming in so cold at temperatures of 32 degrees. If we look at the rates of survival versus temperature, we see exactly what we could have predicted from our pilot study had we really understood how under-resourced these district hospitals were. And when babies are kept warm, they're doing very well. We're seeing the same kind of outcomes that we saw at the central hospital, but they don't have the ability to keep them warm. And so we went back with our pediatrics colleagues, and we looked at what are the leading causes of death for babies. And really you can account for 85% of newborn death with just 3 causes: prematurity, complications during labor and delivery, and infection. And if you think about what are the things you need to do to manage those 3 causes of death, you really need to do 6 things. You need to keep them warm. You need to make sure they have enough glucose. You need to give them breathing support if they need it. Prevent, diagnose, and treat infections. Monitor and treat jaundice. And keep them hydrated and well fed. That's it. You got to do those 6 things. So what are the technologies that are needed to do those 6 things? Really, it turns out that there are 17 technologies that are necessary to prevent 85% of newborn death. And so our goal now is to develop those 17 technologies and get them to places like this. This is Balaka District Hospital, which is very representative of what you would see in a community hospital that serves a population of about 250,000 people. And we think it's possible to equip the NICU at a hospital like this for a total cost of between $5,000 and $10,000. It's not an unimaginable investment. It's less than the cost of, well below the cost of one Western-style ventilator. And so I wanted to show you just in the last couple of minutes some of these technologies that are under development. This is a technology that's made by an organization called DREV in the Bay Area. It's an LED-based set of phototherapy lights to treat neonatal jaundice. We're working on a point-of-care diagnostic to monitor serum bilirubin. You need to be able to separate out the hemoglobin because its absorbance spectra is so much stronger than that of bilirubin. And so again, we've made a little paper and plastic device that allows you to spot a drop of blood and separate out the hemoglobin. Babies have very high hematocrit, 70%, so it's kind of a hard thing to do. But if a baby is jaundiced, you can just look at it and you can see the bilirubin that's present. And we've made, in collaboration with Third Stone Design, a little battery-powered reader that can shine red, green, and blue light through and report the concentration of bilirubin. You can keep babies warm with kangaroo mother care, skin-to-skin contact. Or this is a really cool incubator developed at Stanford that uses a phase change material inside the sleeping bag that you recharge just by dipping in boiling water. Or this is an Indian company that's coming up with a little wristband that changes color based on the baby's temperature. because nurses don't have time to go around and take temperatures. As a result, hypothermia is an invisible medical emergency. This is making that emergency visible. And we're working to develop very simple low-cost incubators that control the temperature that very sick babies are kept at. Apnea of prematurity is a huge problem in this setting. So in a high-resource setting, these premature babies, because they have immature neurologic systems, they sometimes just forget to breathe. We monitor for that, an alarm goes off, a nurse comes over, and the way that he or she would intervene for apnea is she just pats the baby's back or rubs the baby's foot, and that's enough stimulation to get them breathing again. And so what our students have developed is a little sensor that goes around the belly. We started with a stretch sensitive resistor, but now we've actually moved to an optical sensor because it has a better long-term stability, and it detects when a baby stops breathing. But it incorporates two little piezoelectric motors, and if the baby stops breathing, you don't have to wait for the nurse. You just stimulate those motors, and that's enough to get the baby breathing again. And so we began to test this, and our first test was at Rice's daycare center. And so what we did was we put this little band on babies before they went down for their nap. And we did what you're never supposed to do, which is try and wake up sleeping babies. And so you can see this little baby is sleeping, and you can see her breathing. You can see those little palms going up and down. Now we've stimulated the motors, and it's just enough to wake her up. And so we're now evaluating this at Texas Children's Hospital using it with preterm babies, where we've been able to demonstrate that we can indeed detect apnea. Our next step will be to take it to Malawi and combine the detection together with the intervention. Premature babies have a hard time breastfeeding because they're not able to suck to get to stimulate the release of milk. And so moms hand express, and then they cup feed their babies. But it's hard to pour just the right amount of milk into the baby's mouth, and they can aspirate and develop pneumonia. And this is a little cup that's developed by an NGO called PATH, where you pre-pour just the right of milk into the distal tip, and then you can eliminate that complication. We developed these technologies in what's called our engineering design kitchen at Rice, which is an amazing space that we use for rapid prototyping. It's a 20,000 square foot space that's open to all students who are taking project-based engineering courses. And we're now working with Malawi Polytechnic, Malawi's only engineering school, to provide a similar space. At the Polytechnic, they had a wonderful machine shop that was equipped by USAID in 1971, and that was the last time that the School of Engineering purchased equipment. And so while their theoretical education is excellent, their practical hands-on education is being delivered with 1971 era technology. And so here now is their engineering design studio at Malawi Polytechnic that's been funded with support from the Lemelson Foundation. And now what they're doing is they're going right across the street to the hospital, and they're looking for design challenges like this one that came from the orthopedics ward. You can see this home-built system for delivering traction, where basically they just tie a bag of heavy stuff and suspend it off the end of the bed, and you can imagine how painful that is if it gets bumped. So in the first year engineering drawing class, the students have to come up with a solution. You can see here the weight is tucked up under the bed. And then in the spring semester, they actually build their prototypes, and the hope is that they will implement their prototypes. And they're working together side by side with students from Rice to try and develop solutions. Here they're building a little blanket warmer to warm the blankets that the babies are wrapped in immediately after they're born to prevent them from developing hypothermia. So I want to stop by talking about where the world is going next with its sustainability development goals. These are the goals that were adopted to be achieved by 2030 as a follow-on to the Millennium Development Goal. The third goal is the one that's related to health, and it's really the unfinished agenda of the Millennium Development Goals. It's to reduce maternal mortality and to end preventable death of newborns. And I think if we are to achieve both of these things, we've got to include the community that is developing technologies and to focus them on developing technologies that are affordable and robust enough to work long-term in places like this. Let me stop there. I'm happy to take any questions. Thank you.
therefore we have questions. Rebecca's undergraduate training was physics. Her PhD is physics, medical physics. So you can see what a good physics degree would do for you. Questions?
No, I think there's some really exciting opportunities for reverse innovation where you can demonstrate the feasibility of these approaches and then bring them back and use them both in low resource settings to reduce health inequities within our own country, but to reduce cost as well. I think point of care diagnostics is a really exciting area for that. I think it's a little bit more challenging with hospital-based care because changing the standard of care, unless you have really well-documented evidence of efficacy, changing the standard of hospital-based care is very, very challenging. So I think that's something where the opportunity to address the needs in low and middle income countries can then come back and have an impact here. If I had to pick one area where I think it has the biggest opportunity to make an impact for U.S. healthcare, I think the place in our country where we have the biggest health inequities is for adults between the ages of 15 and 59 that suffer from chronic disease. And so if you look at diabetes, if you look at cardiovascular disease, there I think we have enormous opportunities to think about technology development in ways that reduce cost and improve equity and access.
Your paper on plastic technology looks like it can be applied to almost any kind of test. You're only using it for two things. Why not expand it and build a factory that can produce these paper and plastic?
Absolutely. They're very easy to customize. They're very easy to build with really a minimal amount of infrastructure. So I think it's very exciting to think about ways for protein detection, and we and others are also looking at them for nucleic acid detection as well. You can do on-chip amplification in devices like this using isothermal approaches, and looking at ways to push down the limit of sensitivity so that you don't necessarily have to do so much amplification, I think is a really exciting area as well.
You mentioned the importance of a holistic approach to dealing with problems. Step back in another holistic view. What happens to those children in society once an increased number of children entering society? There needs to be some concern over nutrition, education, etc.
Yeah.
As they move on into society.
Yeah, absolutely. And we've spent a lot of time thinking about that. And I think if you look at Southeast Asia as a model for what you need to do, it's a really good model. And so there is something known as the demographic transition. And this is what happens when a country is able to reduce the child mortality rate. What you see is that as families know that their children are going to live, they choose to have fewer children. And so as you bring child mortality down, then what you see is very rapidly thereafter you see a decrease in the total fertility rate. And what happens then in that society is if you look at the dependency ratio, the ratio of working people to dependents, you see that you have that ratio goes down. You have more workers and fewer dependents. And that's really when you have the opportunity for very significant economic growth. And if you look at Bangladesh, Bangladesh is a really good example of a country that grew its economy very significantly, first by bringing the child mortality rate down, then the following decrease in total fertility rate, and then the expansion of the economy, there were also government policies that were put in place to incentivize foreign investment, and a lot of garment manufacturing moved to Bangladesh at that time. There was a big focus on economic empowerment of women, both in the informal and the formal labor sectors. And so I do think that those holistic approaches are really, really important and really interesting. And one of the things that I feel very fortunate to have now the opportunity with resources from the MacArthur Fellowship to think about is, how do you integrate together the efforts that are needed in technology development and technical education and empowering women so that you can do that as efficiently and as quickly as possible? Mm-hmm. Right, sure. So the question was, what are the legal aspects in doing clinical trials in these settings with human subjects? And so in all of the studies that we've done, we go through multiple IRBs, the institutional review boards. And so we always go through the RICE Institutional Review Board. Typically, we have a US-based clinical partner. MD Anderson is the partner in the case of cervical cancer, and we worked with Baylor College of Medicine on the CPAP project. So we go through their IRB, and in addition, we go through local IRBs. Sometimes that's just the IRB at the institution. Sometimes it's the national IRB. At Brazil, we needed to go through the national IRB. In Malawi, when we did the big rollout of CPAP, we went through the national IRB of Malawi. And so it's just like you would do a clinical study in the United States. Informed consent is obtained from the participants or from their guardians if they are minors. And then the devices that we use always are reviewed by the biomedical engineering staff. Typically that's done at the US-based clinical institution to be sure from an electrical safety point of view that they pass all of the standards that would be necessary to use them in the United States. Our commercial collaborator took the CPAP device through the European regulatory approval process, and so it now has the CE mark, and that's what has allowed them to legally export it from the United States and sell it in other countries. So I think it's no different than any other type of clinical research that you would do in a high resource setting in that regard.
Just a question about how sustainable are all those efforts. So you showed a very good picture when we have the room full for all the equipment. So my question is, so when you leave, because not someone else,
Mm-hmm.
so how long is it?
Yeah, so we have a training program for biomedical technicians that we've implemented along with our nursing training program, and they learn how to repair the CPAP devices. The CPAP devices actually are supplied with the replacement parts taped in a little bag on the inside of the device so that you can get through one set of replacing. There's a diaphragm and the pumps that can fail. We've incorporated now also in the curriculum for the biomedical technician training program, training programs in repair of CPAP, as well as all of the other ancillary equipment like oxygen concentrators, suction machines, the pulse oximeters, all of those. I think the continuing challenge is the supply chain for spare parts. And so one of the things we've looked at is, can you improvise local methods of repairing devices? So for oxygen concentrators, the zeolite canisters that absorb the nitrogen from the air often fail, and it's very difficult to recharge them or to replace them. And so our students have been looking at ways to recharge them by heating them. And they've been able to show that you can actually do that in a way that will allow the concentrator to put out 85% oxygen. So it wouldn't meet a standard for a high resource setting, which would be 93%, but it's better than nothing. And so I think a combination of those approaches is likely to be necessary for the foreseeable future.
This is regarding the first part of the talk regarding cervical cancer. So when you said when you introduced man, so it does not mean And you also said that in low-income countries this problem is actually more.
Mhm.
So in low-income countries, when you talk about convenience of transportation, other things comes into play. So don't you think public-private partnership in healthcare is a better way to look at instead of just starting as a private healthcare system?
Well, so the hospital that we're working with very much is a public-private partnership. So it's a private hospital, but they work with the Ministry of Health actually to coordinate the transportation arrangements for patients. So patients actually receive a stipend that they can use to cover their transportation costs to come to the hospital. But even despite that, so many of them are not able to make the trip. And so when we were thinking about what should the approach be, we went to Brazil and we sat with our Brazilian colleagues and really listened to what they thought was needed to solve the problem. And you know, from my perspective, I think as a technology developer, your first job is listening and listening to what the local providers see as the barriers and to what they think are appropriate solutions. So there may be many approaches that will work, but this is what came out of that conversation with them and their knowledge from being deeply embedded in how to solve this challenge.
Time for one more question, sir.
Were you able to help really good interaction with
We did, actually. So one of the things that we did was we came up with a little clip that you could insert into the barrel of an oral dosing syringe. And so it basically limits how far you can pull the plunger back. And so now what the community health workers do is they leave that bottle and they leave an oral dosing syringe with a clip that's pre-installed. And so you dip it in, you pull it back till it stops, and then you give the right dose.
Fascinating science applied to real-world problems. Thank you for a great talk.
Thank you.